Chapter 5, Documentation, Specimen Handling, and Transportation. Chapter Objectives. Upon completion of Chapter 5, the learner should be able to do the following. Describe the uses of a medical record, describe the essential elements of a requisition and final report, list examples of policies and procedures important to phlebotomy, list the basic specimen handling guidelines for maintaining specimen integrity, name sources of pre-examination error that can occur during blood specimen transportation, processing, or storage. Number 6, describe which blood analytes are photosensitive or thermolabile. Number 7, list reasons for specimen rejection. Documentation basics. Patient's records. All healthcare organizations provide a legal record for each patient that describes the patient's visit, tests, and procedures, including laboratory results and clinical progress. The record for each patient is called a clinical or medical record, or electronic health or healthcare record, EHR, or electronic medical record, EMR, the latter of which are computerized versions. The documentation of all clinical events in this record is important for the following reasons: monitoring the quality of care, goals for the patients, how the patient responds, and maintaining a full account of treatment, what was done and why, or what was withheld or why. Coordination of care among all healthcare providers involved with the patient, hospital accreditation and clinical research, legal protection. If something is not documented, it is assumed that it was not done. Electronic medical records are beneficial because they allow for the following features. Handwritten errors are eliminated due to electronic entries. Time and dates are automatically recorded. Electronic orders can be generated for laboratory tests, diagnostic imaging, or other tests. Electronic graphs are available for laboratory results, vital signs, etc. Electronic prescription information is readily available for ordering and retrieving. Pre-established patient education materials can be specified for an individual patient. Digital photos or images can easily be stored. Letters, emails, and other clinical documents can quickly be found. Appointment reminders can be automatically generated. Billing is automated and more accurate. See Box 5.1 and Box 5.2. Box 5.1, common components of a medical record. Personal information, such as date of birth, social security number, or other unique identification number, address, marital status, closest relative known, known allergies, physician's name and diagnosis. Personal and family medical history. Initial assessment completed by the physician, MD or DO, physician assistant, nurse practitioner and/or nurse, medical assistant. Ordering documentation includes MDs and other qualified providers such as nurse practitioners, clinical nurse specialists, physician's assistants, orders for laboratory, radiology, pharmacy, and so on. Informed consent, HIPAA, advanced directives, release forms, treatment consent forms, privacy information forms, authorization forms for release of medical information and similar documents. Patient plan of care, MD and nursing care diagnosis, interventions and patient outcomes, diagnostic test results, results from all tests performed on the patient, medication administration record, known allergies, medication dosage and timing, route or administration, site and date. Progress notes and consultations, patient progress, interventions used in treatment effectiveness, discharge plan summary, plans for special diets, medications, therapy, home health visits, and follow-up appointments, financial information, insurance information, insurance company release forms, and correspondence. See Box 5.2. Tips for documenting clinical information. Healthcare workers involved in blood collection can provide useful information by making extra notations of circumstances related to venipuncture sites, timing, fasting status, or stat priority status. Healthcare facilities have special procedures for situations, incidents related to patient falls, accidental patient injuries such as erroneous arterial puncture, etc., that need to be documented, and for determining who is authorized to make the notations or electronic entries in the medical record. Be sure to follow your health facility's policies. The 5 C's of medical record documentation. Concise. Entries must be factual and to the point. Do not include information that is unrelated to patient's health care. Complete. Entries must be complete and objective. Exclude opinions and judgments. Clear. If information is handwritten, it should be printed, usually requiring the use of blue or black ink, not in cursive. It should be in an easy-to-read format. Correct. Medical records should be error-free, but errors may result by improper additions and/or omissions. Chronological. Generally speaking, medical records should be in chronological order, with the latest entries on top if the record is a paper version. However, electronic medical records may vary in their formats, even though all entries are chronological and traceable. If an error is detected in a medical record, report it immediately to a supervisor and document it. Include all relevant information in a timely manner. For example, if a phlebotomist is unable to identify a patient because of a missing armband, the notation on the correct form should include the time, date, and name of the nurse who positively identified the patient and the phlebotomist's name. Document errors according to institutional policies. If it is a paper copy, note the error by marking a single line through it and writing the word error next to it with your signature, first initial and last name is sufficient. Do not leave extra spaces between your notations and your signature. Legally, this space on the record becomes your responsibility, so do not leave room for someone else to add information to your notation. If it is an EMR, follow institutional guidelines and software requirements for making corrections or changes in the computer. Be accurate and legible. Record facts, not opinions. If it is a paper copy, use ink, print clearly, and do not erase or use correction fluid. Correcting errors. Records should never be changed or falsified to cover a mistake. On a paper document, an error should be noted by marking a single line through it, writing the word error, and signing your initials next to it. Policies and procedures. All healthcare facilities have manuals that detail operating procedures to be followed. Depending on the facility, there may be several manuals: safety manual, administrative manual, employee handbook, specimen collection manual, or just one manual separated by sections. These may also be accessible electronically. Table 5.1 lists the topics generally covered in procedure manuals. These topics are particularly important to healthcare workers involved in blood collection. Healthcare workers may be involved in developing, writing, and practicing these procedures. Clinical alert. Remember that it is very tempting to discuss interesting patient situations with peers, friends, or family members. Although patient situations are learning experience and they may occasionally be discussed with authorized laboratory personnel, this type of information must not be shared with anyone else without the prior consent of the patient or prior authorization. This mandate assures compliance with the Health Insurance Portability and Accountability Act, or HIPAA, which details patients' rights to protection of their health information. HIPAA prohibits the disclosure of any health information unless written consent has been obtained from a patient. Table 5.1, Policies and Procedures for Healthcare Workers Involved in Phlebotomy. Type of policy, specimen collection. Procedures included are patient preparation, type of collection container and amount of specimen required, type and amount of preservative or anticoagulant needed, timing policies such as creatinine clearance, therapeutic drug monitoring, etc., special handling or transportation needs such as refrigeration, proper labeling requirements, priority status such as STAT, emergency specimens, need for additional data when indicated such as fasting versus non-fasting, etc., reporting of critical values, abnormally high or low test results, handling specimens going to or coming from outside organizations, reported incidents such as patient falls or other patient injuries and accidental needle sticks. Type of policies, administrative procedures and/or employee handbook. Procedures included are performance evaluation procedures and job descriptions, disciplinary policies and confidentiality, non-disclosure policies, compensatory time, attendance, annual leave and overtime policies, other human resource procedures, non-discrimination, benefits, dress code, etc. Type of policy, safety. Procedures included are fire and radiation safety, internal and external disaster plan, exposure control plan, hazard communication manual. Type of policy, infection control. Procedures included precautions, isolation procedures, disposal policies, decontamination procedures, hand hygiene procedures, accidental percutaneous through the skin needle sticks, post-exposure procedures. Type of policy, quality control, QC, and preventive maintenance, PM. Procedures included are maintaining appropriate supplies, proper use, storage, and handling of supplies, supplies and equipment maintenance and inventory procedures, monitoring reagents and equipment, stability of reagents and expiration dates when the item should no longer be used, measuring precision and accuracy, acceptable symbols, abbreviations, and units of measure, maintaining confidentiality. Laboratory tests, requisitions, and labels. Regardless of the method used for submitting laboratory tests, requests, or labeling blood samples or specimens, there are standards for required information that each healthcare facility must follow. The College of American Pathologists, or CAP, and the Clinical and Laboratory Standards Institute, or CLSI, have established guidelines or standards for laboratory testing, requisitioning, and specimen labeling. The primary purpose of these standards is to promote the correct identification of the patient and their respective blood samples from the time they are collected, through the testing of analytes, the measurable quantity of blood component, and through the final reporting of test results. Healthcare facilities must maintain updated procedures based on these or other standards of practice. However, studies have shown that paper-based and/or handwritten systems for ordering laboratory tests, requisitioning, or labeling blood specimen tubes are more prone to human error, such as transcription mistakes, misspellings, illegible writing, or transposed numbers, etc. Lost requisitions and duplicate orders. Use of electronic patient data assists in maintaining accurate patient and specimen identity. Standardizing patient identification methodology through the use of electronic data systems is important in reducing errors. Box 5.3. Is it a sample or a specimen? The Clinical and Laboratory Standards Institute, or CLSI, a global organization, has emphasized standardization of terms for purposes of achieving worldwide uniformity. While many healthcare workers use the terms blood sample and blood specimen interchangeably, CLSI suggests the following definitions. Sample. Sample is one or more parts, such as blood or tissues, taken from a system, the patient's body, and intended to provide information on the system. Specimen. Specimen is the discrete portion of a body fluid, such as blood or urine, or tissue taken for examination, study, or analysis of one or more characteristics, analytes, to determine the character of the whole. Thus, an example of the use of these terms would be: a blood sample was taken from a patient and subdivided into multiple specimens for testing in different areas of the laboratory. Transmittal of the test request to the laboratory. A laboratory test request from a physician or his or her designee initiates the pre-examination or pre-analytical phase of laboratory work through the use of either an interactive computer system or a manual request system, paper-based, usually a multi-part request form that is color-coded and is sometimes also used for final test results. See Figure 5.3. Most hospitals use automated electronic procedures for test requests and specimen labels. This fosters greater accuracy in patient identification and specimen labeling. Basic guidelines for required information on a laboratory test request are summarized below. Patient identification. Name, registration, or identification number, and location or unique confidential specimen code that has an audit trail to the patient. Patient gender and date of birth or age. Name of physician or legally authorized person ordering the test. The physician's address is needed if it is different than the receiving laboratory. Test requested. Date and if appropriate, time of sample collection. Source of sample when appropriate, and other pertinent clinical information when appropriate. In case of emergency, the test request is called a STAT request and should be documented. Specimen labels and blood collection lists. Accurate specimen identification is essential and must continue from time of collection through disposal of the specimen. Identification methods vary from manually copying all of patient identification information onto the container to using highly automated barcoded labels. Manually labeling specimens can be time-consuming and prone to errors, so by using electronic systems to generate labels, the problems are eliminated. The correct number of labels for tubes can be generated and productivity is improved. Labeling systems include those that can imprint a patient identification card, or electronically print patient identification information onto the specimen label. CLSI provides requirements for the format and location of every patient specimen label and include 5 requirements whether they are handwritten or produced by portable printer at the time of collection. The 5 requirements are patient name, unique patient identifier, date of birth, specimen collection time and date, a designated space for the phlebotomist identification, a signature, initials, or code. Furthermore, the CLSI standards provide for each healthcare facility or laboratory to add individualized information to the label as needed. Additional information could be as follows: specific tests requested, types of specimen collection tools required for the requested test, type and volume of specimens to be obtained, unique accession numbers compatible with the Laboratory Information System, LIS, or sample numbers to be used for that particular collection time. Special handling requirements such as for pH, temperature, preservatives, routing, test codes, or order status, routine or stat. Collection order of the tubes. Which laboratory section will receive the specimen, hematology, immunology, etc. Who to call for critical results. Smaller labels may be generated to label aliquot tubes. An aliquot is a portion of a blood specimen that is removed, usually after centrifugation, and placed in a separate tube for concurrent testing or for future use. Aliquots are chemically identical to the original sample but should be labeled with information distinct from but linked to the original specimen container. Pediatric collection tubes, cuvettes, and/or microscopic slides, and some hospitals may generate a blood drawing list by floor or unit using the same data. CLSI also provides guidelines for label sizes and formats so that the patient's name is always placed in the upper left corner of the label and other data elements are consistently placed in the same proximity of the label and the label is oriented the same way on the tubes. This reinforces patient safety practices during specimen accessioning, relabeling, and other workflow tasks. Barcodes. Barcoded labels, similar to the ones used for price and grocery items or track and railroad boxcars, are used for identifying patients on an armband, an ID card, etc. In blood specimens, barcodes consist of a series of light and dark bands to relate to the specific alphanumeric symbols, i.e. numbers and letters. So when bands are placed together in a series, they can correspond to a name, patient, healthcare worker or test, or a number, identification or test code, etc. Barcodes are available in several formats, one or two-dimensional, and an optical reading device is needed at the line of sight to read the actual barcode. Barcodes have been proven to improve efficiency and accuracy because they are faster, reducing turnaround time due to the elimination of typing or handwriting information. Radio frequency identification. Radio frequency identification, or RFID, is another automated system for identification and tracking of patient specimens. RFID tags are tiny silicone chips that transmit data to a wireless receiver, such as a computer. In contrast to a barcode, RFID does not require line-of-sight reading with a scanner and can hold more data information than a barcode. The tag can be detected at various distances by handheld or stationary readers/computers, depending on the frequency of the tags. RFID tags make it possible to identify and/or track many items simultaneously. Biometrics. Biometric technology is also being investigated for the applications in patient identification and specimen tracking. This type of technology includes fingerprints, face recognition, voice prints, iris patterns, retinal vascular patterns, and digitized signature verification. Clinical alert. Even with the best technology, there are no foolproof methods that prevent all errors. Patient and specimen identification errors can occur at any time during the pre-examination and examination, pre-analytical and analytical phases of the laboratory cycle due to human error. As specimens are transported, centrifuged, processed, relabeled, separated into aliquots, etc., there are still opportunities for mistakes. Therefore, labeling procedures for samples must include careful placement and verification of each step. For example, when an aliquot is made and labeled from the primary sample, a step should be included that links identification from the requisition and the primary container to the aliquot tube. This verification step should apply to all secondary specimens. serum or plasma that has been removed after centrifugation or of the primary tube. The utmost diligence and attention to accuracy is vital for all healthcare workers involved in phlebotomy practice. In addition, because many tests are highly automated and the analyzer will read the barcode label directly from the specimen tube, labeling the specimen requires specific alignment of the label on the tube. Failure to do so will result in delays reporting test results and loss efficiency. See Figure 5.5. Specimen handling and transport. Sample integrity or quality or completeness of the blood sample can be affected by the method of transport, timing delays, temperature, humidity, agitation, exposure to light, and centrifugation methods. Some, but not all specimens need to be centrifuged before analysis. The CLSI defines basic standard for the handling and processing of blood samples after considerations of numerous variables that might affect laboratory testing during pre-centrifugation, after the specimen is collected but before centrifugation, centrifugation while the specimen is in the centrifuge, and post-centrifugation, after centrifugation of the specimen but before removal of an aliquot of serum or plasma for testing. CLSI committees have studied the research literature that contributes to specific recommendations for specimen handling, storage, and transport. Because there are hundreds of laboratory assays, chemical reagents, and manufacturer's instructions for testing specimen, it is beyond the scope of this text to address them all. It is up to each laboratory to customize their procedures to fit the specific tests they perform. To keep these procedures updated and in accordance with CLSI guidelines, and to provide information and training to phlebotomists as needed. Table 5.2 summarizes basic CLSI recommendations for the handling and processing of blood specimen. It only provides an overview of essential recommendations adapted from the CLSI approved guideline entitled Procedures for Handling and Processing of Blood Specimens. This guideline is much more detailed and provides numerous references and resources for further information. Every laboratory is under pressure to balance transportation time, test accuracy, and specimen rejection issues, so healthcare workers must follow their own institution's policies. Specimen transportation guidelines. Every healthcare facility has a specific protocol for specimen transportation and processing. Most laboratories require the use of leak-proof plastic bag for enclosing and transporting the primary specimen tube, i.e. the blood samples taken directly from the patient. This biohazard bag protects the healthcare worker from exposure to pathogenic, disease-producing microorganisms from leakage or spillage during specimen transportation. The transport biohazard bag may have a pouch on the outside for laboratory requests or other documentation which eliminates the potential for contamination. If possible, the blood specimens in evacuated tubes and microcollection tubes should be maintained in a vertical position with the tube cap or closure on top to promote complete clot formation and to reduce the possibility of agitating the sample, which may cause hemolysis. Handling blood specimen in a gentle manner also reduces the chance of hemolyzing the specimens. For transportation of specimens from remote ambulatory sites, including home health collections, consider the following guidelines. Follow the same handling guidelines set out in standard precautions. Use the same safety equipment that is used in hospital environment, such as closed ventilation, puncture system, gloves, disposable laboratory coat, plastic blood collection tubes, and biohazardous disposal container. Transport all blood collection equipment and specimens in an enclosed or lockable container to avoid spills in case of transport automobile is in a collision. The container should have a biohazard warning label on it and notification procedures in case of an accident. Cold packs should be used in the container for transport during hot weather, or conversely, the vehicle should be heated in freezing weather. For home collection, be extra careful to dispose of waste properly and to place blood specimens in leak-proof plastic bags in an upright position inside a labeled transport container. Clinical alert. Glycolytic action, the breakdown of glucose from blood cells, can interfere with laboratory analysis of some analytes. Also, rough handling and agitation of a specimen can have an effect on hematology and coagulation. Because of these interfering factors, the blood sample should be transported to the clinical laboratory as soon as possible after the time of collection, so that the sample can be processed appropriately and serum or plasma can be separated from the blood cells. The serum or plasma that is separated from the cells must be handled according to specified testing procedures, but in general, serum can remain at room temperature, 20 to 25 degrees Celsius for testing, be refrigerated 2 to 8 degrees Celsius, or be stored in a dark place, or be frozen at below negative 20 Celsius, depending on the prescribed laboratory method. Chilled specimens. As mentioned in Table 5.2, the special types of blood specimens, chilling 2 to 8 degrees Celsius is required. The blood sample should be kept cool by using a commercially available cold pack or by being placed in a mixture or slurry of ice and water, figure 5.7. Do not use solid chunks of ice because parts of the specimen may freeze and hemolysis will result. The labeled blood sample tube should be placed in a biohazard bag before placed in ice slurry. Again, specimens that may require chilling are gastrin, ammonia, lactic acid, catecholamines, parathyroid hormone, pyruvate. Protecting specimens from light. Some chemical constituents in blood, such as bilirubin, are photosensitive or light sensitive and decompose if exposed to light. Thus, blood collected for light-sensitive chemical analysis should be protected from bright light with an aluminum foil wrapping around the tube, such as figure 5.8, or an amber-colored transport bag. Light-sensitive constituents include the following: bilirubin. This liver function test is often used in monitoring newborns with jaundice. Vitamins A and B6, beta-carotene, and porphyrins. Microbiological specimens. Blood, sputum, and urine specimens for microbiological culture need to be transported to the laboratory as quickly as possible so that the specimen can be transferred to culture media and/or the urine analyzed. This enhances the likelihood of detecting pathogenic bacteria. Specimens for blood cultures can also be collected directly into the culture media, which minimizes possible contamination and speeds contact with the culture media. Some specimens require the temperature at 37 degrees Celsius or normal body temperature until the test is performed. These tests include cold agglutinins and cyrofibrinogen. These blood specimens require a regulated heat source, such as a heating block, for transportation and handling purposes. Specimen delivery methods. In larger facilities, the laboratory is most often the department responsible for the delivery of blood specimens to the location where they will be analyzed. However, other types of specimens, such as CSF, urine, and sputum, are commonly delivered by transportation or nursing staff members. Whatever the site, guidelines should be available for the safe and efficient delivery of specimens. These may include a schedule of pickups, how to deliver stat specimens, where to place specimens, when to double bag specimens, how to log in specimens, how to store specimens and for how long, and similar procedures. There are a variety of methods to transport specimens. Courier services. Courier services are used for off-site areas such as reference laboratories, blood drawing stations, or remote clinics. Again, consideration prior to and during transportation should include adequate packaging and handling. This is especially true in hot or cold temperatures. Hand delivery. Hand delivery often involves the use of a log to document the receipt of each specimen. In a hospital setting, the blood collection trays or carts are typically arranged to hold numerous specimens awaiting delivery to the laboratory. All specimens should be secured vertically, closures up, using test tube racks, a holder for microscopic slides, plastic holders, cups, and/or a leak-proof container for ice water. Specimens such as CSF or bone marrow that are acquired by invasive procedures are often delivered by hand. Pneumatic tube systems. Pneumatic tube systems are used to transport specimens, patient records, messages, letters, bills, medications, x-rays, and laboratory test results. The CLSI reports that many studies have documented the validity of laboratory results after specimen transport through a pneumatic tube and suggest that the tests most effective, lactate dehydrogenase, potassium, plasma hemoglobin, and acid phosphatase, are compromised because of the disruption of red cells. Also, if samples must be kept at body temperature, such as testing for thyroglobulins and cold agglutinins, they should not be transported in a pneumatic tube system. However, the majority of analytes are not usually affected, so this is an efficient means of specimen transport. It is recommended that blood collection tubes be placed in a pneumatic tube with a shock absorbent inserts, padding the sides, and with the tubes separated from one another, or to prevent spillage or breakage, clear plastic liners are also commercially available, so that if leaks do occur, they are visible and are contained to prevent contamination of the tube system, the carrier, and the personnel handling the specimens. Gloves should always be worn when loading or unloading specimens from the transport tube container, because there may be contaminated with biohazardous specimen leakage that is not visible to the naked eye. Transportation by automated vehicles. Transportation by automated vehicles uses a small, motorized and/or computerized container car attached to a network of track that is routed to appropriate sites in the laboratory and nursing stations. Specimen storage. Each laboratory should have specific criteria for keeping specimens stable during storage and for determining time and temperature requirements for their testing procedures. Test results may exhibit significant changes caused by time delays, even though some analytes may be stable for longer periods. CLSI suggests that cells be removed or separated from serum or plasma as soon as possible after collection. The results of some laboratory tests change significantly if the cells remain in contact with the plasma or serum, yet some may remain stable for longer periods of time. Manufacturer guidelines should be followed closely. Because a test result is only as good as the specimen it is performed on, there are occasions when a sample or specimen, such as blood or urine, must be rejected. This is an uncomfortable situation because it means that the patient may have to undergo another venipuncture or another trip to clinic. Box 5.4 indicates important criteria for specimen rejection. One of the most common reasons for sample rejection is that the specimen is hemolyzed. Hemolysis of the red blood cells, disruption and lysis that results in the release of hemoglobin from the cells. Hemolysis can interfere with laboratory testing and results. Sometimes it is caused by the patient's condition. However, oftentimes hemolysis is due to a difficult venipuncture and/or improper handling of the blood sample. If the specimen tubes are roughly handled, shaken vigorously, or if supplies are not used correctly during the venipuncture procedure. In the latter case, the problem can be prevented by careful and correct use of phlebotomy equipment and supplies. When a problem with a blood sample arises, the healthcare worker who drew the sample and supervisor should try to solve the problem initially. Errors should be acknowledged and documented with corrective actions. Other personnel may be involved as needed. Honesty and ethical communication are mandatory. Clinical alert. If a blood sample is not acceptable for testing, it should be disposed of properly. A request for a new specimen must be initiated by an authorized individual. The situation should be documented and the patient's physician should be notified. Box 5.4, factors for sample rejection. The test request does not match the labels on the blood sample. The label is unreadable or partially missing. Anticoagulated tube contains blood clots. Excessive delays in processing the specimen. Hemolyzed blood specimen, except for tests in which hemolysis does not interfere with analysis. Improper specimen transportation, temperature, or storage. Improper blood collection tube, the correct additive is a requirement for specific tests. Incorrect blood volume, too much or too little in the collection tube. This can affect the blood to additive ratio and affect the accuracy of test results. Lipemic blood specimen, cloudy or milky appearance of serum due to ingestion of fatty foods. Non-fasting blood specimens, unless appropriately noted. Use of outdated supplies to collect the specimen, the expiration date is passed. Variation in patient posture, hormone levels change based on whether the patient is sitting or reclining. Time specimen draw at the wrong time. Unlabeled, unidentified specimen tubes, and contamination of the urine specimen. This concludes Chapter 5.